You can start.
Yeah, yes.
Yeah, you can start. No
Uh,
problem.
okay, okay. Good evening, ma'am. Good evening, teachers. Good evening, colleagues. Today I'm going to present the case. Uh, my patient is a 72-year-old lady, educated up to the fourth standard, housewife, coming from lower middle socioeconomic class. He is hailing from Viara, Surat, admitted at the seats at 10th of August 2022. History given by herself and her son, and it's reliable. She presented with chief complaint of diarrhea for 6 months, and anorexia and weight loss for 3 months, and pedal edema for 3 months. Uh, History of present illness. Patient was well before the 6 months. Then she developed diarrhea for 6 months. Incidence onset initially intermittent but continues for last 4 months. Watery in consistency, non-foul smelling, 3 to 4 times per day.
I'll just stop here. Just go back to the previous slide. This chief complaints. Don't use the word diarrhea. Just say loose stool.
Okay.
Yeah, don't use these big terms. No? Some examiners nowadays they go towards management, but still you can just say loose stool for 6 months. Otherwise, you can start from here. What's the definition of diarrhea? So start just say loose stool for 6 months.
Okay.
Okay, and anorexia and weight loss for 3 months. Now, pedal edema must be part of the diarrhea, no? So don't have too many chief complaints.
Okay, ma'am.
The pedal edema must be nutritional, so it's very difficult for you. Then, if you see pedal edema 3 months, they bring in the liver causes, cardiac causes, renal causes, and all that. So just put diarrhea for 6 months and anorexia and weight loss for loss of weight and loss of appetite. Be very simple. There are some examiners who are finicky about this. Just put loss of weight and loss of appetite for 3 months. Okay.
Okay.
So now move on. Okay, next slide. Yeah, move on. Now, the other important thing is, patient was well before 6 months. So if it is 6 months, so this is August, no? So see, in the month of February, patient was doing well until the February of 2022. Because I do not know when you took the case. Maybe it was last year's case or the year before last. So give us a good temporal the temporal relationship is very important. No? So then immediately we go back to February. Our mind goes back to February of 2022.
Okay.
And always start by saying that the patient was doing well. When you say doing well, when it's a diarrhea, you should say that instead of loose stool for 6 months, from the month of February 2022, and say until February 22, her bowel movements were 1 per day or 2 per day with a Bristol score of 4. When she noticed a change in the bowel pattern over a period of time since February of 2022. So then it cannot be on one particular day the diarrhea starts. It will be over a period of time. Yes. So always give that temporal relationship. That's very important. Because when you say before 6 months, we're just trying to find out which month, which year. Okay. So she had loose stool for 6 months for the month of February. Okay. Okay, ma'am. So diarrhea cannot be insidious, just over a period of time. You just say there was a change in the pattern and the frequency of stool over a period of time. Okay. And initially it was once in 2 months, once in 15 days or 20 days. And now it has become more frequent, something like that. So that we know that some change in power pattern has occurred. Okay. When you say intermittent, then you'll have to say that in a month, how many times you would get loose stool. Okay. When you say intermittent, then it is, if it is episodic or intermittent, then that means there are periods of normalcy in the beginning. Yes. And maybe she was constipated then. We do not know. So just even when you take this case in the outpatient, I would first say that, okay, she's had loose stool, some problem February. Then I just ask, did it occur all of a sudden on one particular day? Or then she'll say, oh, no, it was for the initial 2 months, I was passing loose stool for 4 to 5 days in a month, or at least once in 2 months. But now I find it's almost daily. So that's the way we'll move on. Yes. Then it is easy for you to describe. And then important, you have to say what happened in between the episodes. That's most important. Okay. Supposing she says it was initially twice a month and it will last for 3-4 days. That means in between she's normal. So then you have to tell either it was medication or what it was. So just get that, draw a graph draw the onset and say there is a diarrhea. Initially, then you say February, March, April, May. Then you can also say until month of May or so. And then since about last 2 months, 8 to 10 weeks, then you can bring in that. That is just a way of presenting it. Okay.
Okay.
Okay, then 10. Initially intermittent, but now continues for past 4 months. That is since month of, that's what I said, no? So August, you have to go back. August, July, June, May. So since month of May.
May. Initially, it was intermittent, used to occur 2 times in a month. But for last 4 months, it's been continuous. Water consistency, non-false
So
smelling.
first will be the frequency, no?
Frequency.
Then only the consistency, no? How can you describe a stool without telling the frequency? So you just have to say, and that's what I said, the Bristol, she was passing just once or twice a day of what did I say? Normal color and consistency prior to the onset of, prior to the month of February of 2022. When she noticed there was a change in the frequency, which now what was 1 to 2 has now become 4 to 5 times per day. 4 to 5 times per day, and at 1 to 2 times during the night time. Such episodes of looseness of stool would occur at least once or twice a month, because you will not remember. The recall is not so much, you know. And then you describe that the stool was then watery in consistency on these occasions. That's how you say, okay?
Yes.
And this non-foul smelling, no? Dr. Martha would always say which stool is not foul smelling. So no, foul smelling is usually when you may have a lot of hydrogen sulfide or there's a hemorrhagic stool, no? Melanic stool.
Yes.
Okay, continue. Continue.
Stool frequency was 3 to 4 times per day, with 1 to 2 times nocturnal frequency. Was watery in consistency, non-foul smelling, large volume.
Now, large volume, specify the volume. Either it's measurable or it's not measurable. So you can say when it's large, that means, you know, she gets dehydrated. But if it is small, she's less likely to get dehydrated. So they will ask you, doctor, what is large? See, there are examiners like us at least who want to know large. When you say large, each time, there are some patients who pass normal stool and yet they feel tired after passing stool. They say, I passed one large stool, doctor, once or twice, but at the end of it, I get exhausted.
Okay.
So when it's formed, exhaustion is unlikely, but it's watery, then they're likely to have fatigue. So large volume, how do you quantify the stool?
Ma'am, actually,
especially in a Western closet, you cannot quantify. So how do you roughly quantify?
Roughly, ma'am, patient is telling that the amount of stools which she used to pass before, it's quite obviously quite more than the she was passing before.
That is frequency, but the volume should be normal then. Volume would be normal, no? If it's formed stool, is a normal volume. But now the volume is more, so it's a small quantity. If it is small, frequent, then it is rectal. Large volume would be, say, about a cupful or about 100 to 150. They'll say, how did you quantify it? Then you can say that what was earlier just a small form stool is definitely, the volume is much more. And soon after that, she would get, that's what you need. So just imagine if a person passes 3 to 4 times a day, 1 to 2 times at night, large volume, what will happen to the patient? Not related to me. What will happen to the, bring in the consequence of that particular 3 to 4 times. She passes 3 to 4 times a day. But at the end of it, if she passes 1 liter each time, then she'll get dehydrated. No?
Yes, sir.
Then you bring in the association and all that. What is the effect of this loose stool on her health? You have to mention. So this is how you would say. So I would say that she had looseness of stool since the month of February of 2022 until late December of 2021. The bowel movements were often normal. She passed just 1 to 2 per day of normal color and consistency to the Bristol stool score of 4. However, in the month of February, over a period of she found a change in the bowel pattern. What was 1 to 2 per day was now becoming 3 to 4 times during the day and at least 1 to 2 times during the night. Each of these episodes was associated with passage of fairly large amount to the extent that at the end of the day, she would find she's got fatigue, she's got tiredness, and she would often get dehydrated and she would drink water frequently just to get that. Or she would require admission because it is intermittent. This type of a particular frequency and consistency continued for at least 1 or 2 occasions in a month, which would last for about 3 to 4 days. Then bring in the associations because we just want to know what's the effect of that. What is this diarrhea that is causing this looseness? Is it having an effect on her health in the form of tiredness, exhaustion, fatigue? Then bring in associated. Then comes the pain. After once you finish the frequency, next is the pain. You want to know it's painful or painless, and then starts the rest of the history. Okay. So large volume, not related. Okay, continue. Not related to meal.
Meal. But fasting reduces the frequency, but reduces the frequency, but it not fully cover. Means it still passes loose stool of at least 2 to 3 times in a day, which is associated with the bloating, gurgling, and abdominal discomfort. And it is not associated with the urgency, incontinence of stool, tenesmus, blood, or mucus per stool.
Okay.
She also
No. Your diarrhea is totally incomplete. No, how can you just finish off the diarrhea like this? Bring in all the factors that you want to say, because you've gone to the second complaint. That's what I said.
Okay, ma'am.
Now tell what is it that you want to convey? In a patient who has almost for nearly 6 months or so, who has frequency of stool which is about 3 to 4 times and 1 to 2 per night, large volume, which was initially, this would last just for 1 day earlier, or it would last for 3-4 days.
It used to last for 3 to 4 days.
So 3 to 4 days, if a person passes large volume, what will happen at the end of 3 days? Just in your mind, just think, what are the possible causes now? So that will be your history. When all can you get the situation when a person passes fairly large volume all of a sudden 3 to 4 times per day, and then it's also 1 to 2 at night. There's not much of abdominal pain. What are the differentials that is crossing your mind? Because the history will move only from there on. And then which of these can cause loss of patent appetite? What are the things that are crossing your mind? When all can you have this 3 to 4 times per day, 1 to 2 times per night? And then there is frequency. Most important is the pain. Each of these episodes, I would say, would be classically characterized by passage of stool that was watery in consistency. It would be about 200 to 250 ml each time. And consistency was watery. There was no preceding abdominal pain. It would be spontaneous. At times, she would find that there would be a reduction in the frequency if she was not eating. But most of the times, it was independent. It was likely to be independent. It's likely to be independent of that. So it will describe such episodes will last for 3 to 4 days and lasting at least for 4 to 5 days. And then as a result of this, what would happen? She would often have to go to the hospital, or she would take local medication, and there will be some response. And then in between episodes of pain, she was fairly normal. And then you say these episodes of abdominal loose stools that she had was associated with. Now you have to think, what are the possible causes I should discuss? Not associated with any abdominal pain. There would be some discomfort. There would be some gurgling. And then she would rush to the toilet to pass stool. Okay? And then what are the other things that you would like to mention? Once you've got the frequency, you've got the consistency, you've got the nocturnal frequency. What are the other things that then you've mentioned about the gurgle? What are the pain you mentioned? What else would you like to say? As a consequence of this, now you have to mention what are the consequences. So in your mind, be very clear. Are you dealing with colon, or you're dealing with the small bowel, or it's a combination of both? So that you have to first get in your mind. Or is it a systemic disease? That's all. One is it's a systemic disease. Number two, it is either a small intestine or a colon. From the history that you're describing, colon seems to be out of the way.
Yes, ma'am.
There's nothing as far. So now if you focus your attention first, we finish off small intestine as possible causes in your mind, and then proceed for the systemic disorders. Whereas in a patient, how old is she, you said? 72. So in a 72-year-old female, I think more of a systemic disorder rather than a primary local pathology. My mind would work in that direction. So what are the possible causes of this diarrhea occurring all of a sudden? That will be your no history. And then you'll mention about the consequences of the diarrhea. And then in the consequences, you'll first finish off the nutritional deficiency, and then you'll come out with a history of anorexia and weight loss. Understand? So get that sequence of events. So let us start from the esophagus. Okay, esophagus cannot cause loose stool. What are the gastric causes? So causes in the stomach that can present as sudden volume, watery diarrhea, which is about 3 to 4 times per day, also nocturnal disturbance. What are the possibilities?
In the stomach, maybe
One is Zollinger, one is
Zollinger,
Zolling-Ellison syndrome. Then it can be
yeah.
eosinophilic enteritis. It can be,
Eosinophilic
then it can be Menetrius. Then it can be a lymphoma. So then you say, okay, then I should ask for history of anorexia, weight loss, maybe there. But you say early satiety, is fullness. But don't say no history. But keep that in your mind. So I must ask, was there any history of early fullness? Nothing is there. So it's unlikely that it's the stomach, because if it is any of these symptoms, Zollinger-Ellison will present as watery diarrhea. They will have symptoms of acid peptic disease. But don't say no history. But in your notes, you should have written, I would just draw a diagram and say in the stomach, okay, these are my differentials in the stomach. Okay, the patient can have diarrhea in the small intestine from the stomach. Either it is Zollinger, it can be Menetrius, it can be eosinophilic, it can be lymphomatous, or it can be eosinophilic. So these are my 4 or 5 causes from the stomach. Yeah. If these are the causes, what are the important no histories I should ask for? There's no early history of satiety, no fullness, there's no acid peptic disease. So I'll go slow on this, and I will try not to bring too much of the stomach as an etiology. Yes. Now you come to the small intestine. Now in the small intestine, it can be from the duodenum or upper portion of the jejunum or the terminal ileum. Now, if it is the duodenum, say second and third part, you will start getting all the deficiencies. So then I must say, what are the common causes in the duodenum? It can be tuberculosis. So start again from the lumen. From the lumen, it can be just bacterial overgrowth. So she gets antibiotics and she settles down. So in the lumen, it can be most likely, maybe it's a small intestinal bacterial overgrowth due to systemic disease. So she has this intermittent watery diarrhea. So I must keep that in mind. That's the lumen. Within the lumen, you can get parasites. So maybe giardiasis, it may be cryptosporidiasis. So I must ask for high-risk behavior. I must ask cryptosporidiasis will behave like cholera. So I must ask for dehydration. She requires IV fluids. That's how I would write by the side. And then you'll find that you're getting one by one. So what else in the lumen? So one can be giardiasis. It can be small intestinal bacterial overgrowth. And then in the wall, now you come to the wall. In the wall, you have first the brush border. So first contact will be the brush border. So brush border, I must ask the history of fat intolerance, lactose intolerance. So should have I asked for that? But then once you got all this, then you put it in an order. So once you've got the brush border enzyme for us, which is basically lactose intolerance, then you come to the enterocyte. I'm coming one by one layer. In the enterocyte, it can be cryptosporidiasis. Okay, it can be one of these, the various stages, A beta lipoproteinemia, not at this particular age. Okay, then it can be some of these heart valve disease, cystinuria, but they're all pediatric causes. So enterocytic causes are unlikely or less likely. Then you move to the lamina propria. In the lamina propria, now my differentials are huge. A, is it a tropical screw? Should I ask you a question? So that on nutritional. Number 2, celiac disease. Then I must ask for gluten intolerance. Can it be a Whipple's? Whipple's is a multisystemic disease. That means I must ask for joint pain. I must ask for any neurological symptoms. I must ask for, so Whipple's will come as a DD. Is it actually an IgA deficiency syndrome, CVID, and she's immune deficient state? And therefore, is it an HIV-related watery diarrhea? So I must ask for high-risk behavior. They can present as watery diarrhea. Can it be an A-gamma globulinemia? That cannot occur at this age, but it's at a younger age. So that also gets shortlisted. So this is a way you should approach. Then you come down to the muscularis. Then you have collagenous screw also, but it's not usually common in the small intestine. Then you come to the submucosa. In the submucosa, we have only one or two. One is it can be tuberculosis, it can be Crohn's disease. Crohn's disease is through and through. Crohn's will be, again, a pain will be there. It's an ulcerated lesion. They can have diarrhea, but periumbilical pain will be there. So that comes down again. It's unlikely, 72 years old, presenting for the first time. Can it be lymphoma? Yes, lymphoma will come as a DD. So I must ask for anorexia and weight loss. I must ask for all the B symptoms. This is the way you approach. Once you have the approach, either it's a small intestine or proximal jejunum, duodenum or jejunum, all this will be there. And then you come down to the muscularis propria. In the muscularis propria, they're all mixed connective tissue disorders. Also, I must ask for rheumatoid arthritis. I must check whether she's got SLE. Does she have Sjogren's? So is it actually a vasculitis with small intestinal bacterial overgrowth or amyloidosis that is causing this problem? Or is it scleroderma? but they'll all be SIBO. They're all SIBO related. And then when you come beyond the muscularis propria, you come to the serosa. Serosa, again, there's nothing much except eosinophilic. Then, okay, I must ask for ascites. I must ensure there's no abdominal distension, because if it is abdominal distension is there, that is fine. And when you come beyond that, you have the nodes. The next one is the nodes. Venoic nodes, again, tuberculosis and lymphoma will come as one of the DDs. Okay, now what was PAN? I've said, so I started with brush water. This is how you approach. So when you're asking the question, I will first say no history of any intolerance of the food. Then for me, and now what are the causes that be transmural? Transmural will be Crohn's disease. Yeah, eosinophilic gastroenteritis, eosinophilic enteritis, and it will all be transmural. They're all diseases that can occur through and through the GI tract, but they'll all be painful. So my first thing is, if it is ulcerated, it will be painful. So I must ask for pain. I've got my DD. Now, when you move beyond this, you've finished all this. Coming to the structure, jejunal diverticulosis, multiple jejunal diverticulosis, or it can present as by folic acid deficiency. Maybe there's a B12. I must just check on that. They'll ask me a question on B12 versus folate. So jejunal diverticulosis can just present bacterial overgrowth. So she's got watery diarrhea, and therefore it is this. Okay, or is it actually a small bowel? Now you're coming to resections. Is it actually a small diarrhea which you had surgery earlier, and therefore it's coming in the past, or is it coming now, or is it a post-GJ status? So I must ask for history of surgery. Yeah, and then from there on, you move to the systemic disorders. Systemic disorders are all endocrine disorders. So thyroid, I have to rule out thyroid. I have to rule out all other conditions which can cause diarrhea as a manifestation. Thyroid, diabetes, or Addison's, all these will come. So once you have this in your mind, those will be your important no histories. In a patient who also has anorexia and weight loss, that is already there in our mind, if all the causes that we have discussed, anorexia and weight loss, then is it actually malignancy? If it is malignancy, what are the common malignant lesions that can cause? You understand? This should be the approach to the patient rather than go. So therefore, and what are the consequences? These are the causes. What are the consequences of this? The consequences of this will be what all can happen. They can have nutritional deficiency. More proximal the lesion, you have to ask for tetany, you have to ask for carpal spasm, you have to ask for night blindness, you have to ask for difficulty in adaptation at night, you have to ask for joint pain, you have to ask for edema of the leg. Macroscopic and microscopic macronutrient and micronutrient deficiencies. That should come as this before you go to the history of weight loss and loss of appetite. What's the consequence of this diarrhea?
Yes, sir.
Once you get the consequences of the diarrhea, then you would know that if these are the consequences, then you can almost pinpoint where the site of lesion is. You understand? So first is pain has to come up as a distinct entity. And what are the consequences of this? Amongst all the causes that we said, which are the ones? Food intake increases, food decreases, or is osmotic. So the other way of this is one way of classifying based on the site of involvement. The other way is, you all know it can be osmotic, it can be secretory, or it can be a bloody diarrhea. We call it more as fatty diarrhea, or a watery diarrhea, or a bloody diarrhea, rather than call it as an inflammatory diarrhea. Because Dr. A. Puri does not like the word inflammatory. Inflammatory is actually a pathological change in the intestine. Inflammatory is pathological. No? When you're describing watery diarrhea and fatty diarrhea, which is macroscopic, where you bring in as inflammatory. So he calls this bloody diarrhea. So the diarrhea can be bloody, it can be fatty, or it can be watery. So watery will be osmotic and secretory. You got it? So one is, you can characterize this as osmotic or secretory. That has to come out in the history. And you already said it's loose and watery. So fatty, you don't have to describe. Bloody also goes off. So you're left alone with either an osmotic diarrhea or a secretory diarrhea. When you've got the osmotic and secretory diarrhea, then it is which portion of the intestine that is getting involved as a consequence of this. Now, can you tell in the same slide, what are the consequences of this loose stool? So now it has become continuous, it is painless. As a result of this, now you tell what happened. Don't talk of anorexia and weight loss, that will come much later. What are the deficiencies that have occurred during the 6-month period?
During the 6 months, ma'am, she required multiple hospitalization for the same, and she was given IV fluid and other supportive treatment. So she required multiple admissions. This may be related
No, so
to
you just say for each,
dehydration.
so you just say that as a consequence, this watery stool, she would often get dehydrated. She would take, and to such an extent that she would require temporarily IV fluids, and then she would get back, and then she'd have some relief for 2-3 days, and to have just a recurrence of the symptoms once again.
Yes.
Okay. Now, during the 6 months, so this is broadly she's requiring. So what has happened to her health as a result of this? What all deficiencies has she acquired because of this?
She can acquire vitamin deficiency.
No, what all? No, you're telling your patient. You're telling your patient what happened.
What happened, ma'am? She developed. She had a bloating, gurgling, likely carbohydrate malabsorption.
That's okay. Don't discuss like that. You tell the history so that I just want to assemble it. So she has gurgling. She's got borborygmy. She's got flatulence. That's one. Number two, there is also history of edema of the legs. So you've got a hypoproteinemia. Yeah. Then number two. Number three.
Ma'am, she doesn't have any oral ulcer, glossitis, angular stomatitis.
No, that is also, you say there's no history of any burning of the tongue. There's no history of where she's able to eat well, because that is on examination. All your other things, no? Cheilitis, glossitis, and all part of examination. So you'll have to say that she's able to eat, but the appetite has decreased. However, there's no history of paresthesias, numbness, tingling sensation. There's no history of oral burning sensation of the tongue or oral cavity. Her intake has fairly been good. There's no history of any loss of adaptation to night at night time. So this is the way you build up the history. This is the way you build up the history. And as a result of this, overall, there has also been, in the same period of time of late, as a result of this, she's also lost appetite and loss of weight. Now, loss of appetite and weight may not be part of it may be just part of the same process, because she has this frequency after she passes through, so she starts taking less and less. Once you take less and less zinc, everything comes down. So then they develop agusia. Then therefore there may be as a consequence of this. One is consequence, or it is a disease that is causing anorexia and weight loss.
Yes, sir.
Now comes after this, what are the important no histories that you would say? Come on, move to the next slide. This is the approach. In the exam, if I were to see this case, nobody immediately can say, oh, this is a watery stool. Now let me, for me, 72-year-old, I first finish off thyroid, diabetes and all that. And then go to the next previous slide. You had one, no? Go to the previous slide. Yeah,
well,
this
actually,
one.
I explain all
say, no, you read out.
She also complains of weight loss of 8 kgs in last 3 months. She also complains of loss of appetite for 3 months, and oral intake has been reduced to around 50% from the baseline.
That's all. No. This diet will come later.
Okay. I should not speak over. She also noticed pedal edema for last 3 months, which was insidious. Gradually, initially, she started on the dosam of food.
So all this additional thing does not. It doesn't make any sense to me. No? So she's got edema of the lower limbs, which is progressive and increasing. However, there is no history of paresthesia, numbness. So hyperproteinemia is there.
Yes.
Hyperproteinemia is there. There may be some carbohydrate malabsorption. But is there any other malabsorption of fat? So that weight loss, maybe there's also steatoria. We're not able to pick that up. But what about the macro and micro? So micronutrient deficiency, to say. So don't say it draws some of the food and goes up to that. You're not interested at all. Okay. You're not interested.
Yes.
Not us with the redness. Why did you ask that? So this is what happened in the exam. Why did you ask for redness of foreline skin, pain and discharge? What is that? Why did you ask all this? Would you ask in the outpatient clinic? She's coming to the OP with diarrhea, and you can see she's got edema of the leg. When you ask for this, not also redness and overlying pain and discharge, it makes no sense.
Yes, ma'am.
It makes no sense.
Okay.
Then it becomes cellulitis, no?
Yes, ma'am.
Without puffiness of eyes, decreased urine output, orthopnea and PND. So these are all concerned. So history is quite simple. Mention all that. You have to make, most important is the pain.
Yes.
Is it painful or painless? And then you've already identified slightly the small intestine, so you're getting all the consequences of that. You've not mentioned anything about the nutritional deficiency, which is first and foremost. And then mention, is it painful or painless first? And then the consequences of this, merge it into a nice history and say, during this period of illness, there is no history of oral ulcers, no history of glossitis, or she has got or burning sensation in the oral cavity. There's no paresthesia. Day to day, she's able to carry on. That is most important. Bring in the most important global physical assessment scale. When you mention about the diet, that will go on the global physical assessment scale. What is her physical assessment? As a consequence of this, for the last 6 months, while she's able to attend to her day-to-day activities, she is not able to do as much as it was, and her performance scale has come down from 0 to 1 or 1 to 2, whatever it is. After you finish this, then you say, during this entire period of illness, now you bring in your, don't say no history, put your next slide. There are too many no histories. Merge it into one based on what is there in your mind. Is it intraluminal or is it in the wall? You understand? You cannot have so many no history. Now, you read each one and tell me why you asked. See, abdominal pain is not here. Abdominal pain is there.
Okay.
Yeah. And if there's no abdominal pain, there's no vomiting, obviously.
Yes, ma'am. Then I asked ma'am abdominal distension for any episodes of obstruction or development.
Well, that will be painful, no? Yes. That's what I said. Once it is painless, if it is painless, I will not ask for question of abdominal distension at all.
Okay, ma'am.
Including the lump. Lump can be there. Okay. Non-luminal lump can be there. Awareness of lump. Okay. But supposing she had a lump, if she had a lump, again, it will not explain the diarrhea because it has to be intramural or it has to be mucosal. No history of cough.
Cough, expectoration, dyspnea. I asked for ma'am or any extra intestinal presence of tuberculosis or secondary.
So just say during this entire period of illness, there's no history of any fever, there's no history of cough, that's all. And there's no history of generalized anasarca. Urine output has been normal, finished. That finishes the whole thing. It rules out your breathlessness, it takes out your this thing, it also takes out your renal pathology. Okay, now passing of worms. Now, which worm will cause diarrhea, doctor? See, they'll ask you the life cycle of all these worms. Which worm is going to cause diarrhea? Passage of worms. Which identified worm will cause diarrhea? None of them. No. Neither a roundworm nor a hookworm. These are the only worms that a person can see, or a threadworm. These are only 2 or 3 worms that can be seen. So don't bring in all this. This is exactly what happens exam. Passage of worms. Now, they'll ask, doctor, how many times you've seen passage of worms and which worm? Now, they will stop. They will not allow you to continue with the history. Oral ulcers, skin rash, redness of eyes. Okay, you want to bring, but there's no pain. So it is non-bloody diarrhea. But any other condition, redness, skin rash, oral ulcer can cause diarrhea. So you can get Behçet's. So Behçet's can present with diarrhea. So for that, you just bring in the autoimmune, all the things together. During this time, there's no history of oral ulcers. There's no change in the eyes. There's no history of joint pain, arthralgia, or arthritis. Finish. That finishes the inflammatory process or any skin lesions that have been identified during this period. Which skin lesion can present? So if you have suppose dermatitis actiformis. Yeah. So before this, you mentioned about the tolerance. No, you've not mentioned anything of the tolerance to the food, and you've gone to the no history. That is why I said, just draw a figure of the entire GI tract. Take up the colon out of this stomach. Okay, I must look for these signs. I must ask for this history. In the small intestine, these are the causes. I told you, intraluminal, what are the causes I should ask. Then brush border, it doesn't matter. First, brush border, lactose. So I should ask for lactose intolerance. So that's one important history which I missed. I should have asked for that. Any history of milk intolerance. And then you mentioned about discussed all the laminar propria causes. So joint pain, I must ask. And I'll ask for any other signs of immune deficiency state like cough, fever, long-standing. So I must ask for immune deficiency state, whether she has that problem. So that is one possibility. And then you have to ask for the celiac. And for celiac, I must ask for wheat intolerance. Yes, so those will be an important no history, not passage of worms and all that. Now, why did you ask for blood transfusion? Look at this. Why did you ask for blood transfusion? What is it? What's the relevance of blood transfusion? If you want to talk of occult bleed, then you'll have to bring in right in the history that she had fatigue, she had exhaustion, she had time. How will you differentiate? This is a Viva question. How do you differentiate anemia due to blood loss vis-a-vis lack of intake, reduced intake? So reduced intake can also cause iron deficiency. Loss of blood can also cause iron deficiency. So if they have breathlessness, they have fatigue, and they have a palpitation, and they have giddiness, or they have a blackout, then it's a blood loss. Okay, but if it is, that is blood loss. But if it is lack of intake, they will not have any of these symptoms. It is reduced intake of food. So that's also, suddenly you cannot say, I was just wondering why you asked for blood transfusion. Because now I'm more into the liver. I was wondering, what does this hepatitis B to do with this? You know, this is, so there are people who are more dealing more with the hepatology. Then you're wondering why suddenly when blood transfusion has come in the history. Understand? So the blood transfusion is of no relevance. There you will say, there was so much of fatigue, exhaustion. Occasionally she would have blackouts. When she would get up from the bed, she would have swooning and giddiness. As a result of which, when she was evaluated by a family physician, she required blood transfusion. So history will come there. Not here. Suddenly don't say no history of blood transfusion out of the box. And don't bring in similar complaints in the past. That is the past history. Heat intolerance and palpitation is fine. That is good. That is important because now you're going to the systemic disorders. Then you have to say patient is not a known diabetic. There's no history of any heat intolerance and there's no history of palpitation. That means should be a diabetes and this, both of them. But if they have a dyslipidemia, say sodium and potassium, so it's a villous adenoma. It is presenting like intermittent. So they'll have hypokalemia. Then you can have some amount of weakness of the limbs while she's walking. So those are the things that you highlight. Just think of all the consequences and just relevant only to that. Okay? Bone pain, bruisability, unstable gait, and all will come there as a consequence, not as a no history.
Okay.
Glossitis, cheilitis is for you to see. You say burning sensation over the tongue. Over the tongue. Cheilitis is also what you see. Now, this recent traveling, most of you keep talking of recent traveling. What is this recent traveling to do with the 6-month diarrhea? What is the 6-month diarrhea to do with a travel? Travel history, when you ask. Suppose I have traveled to some place and then after I return from that place, I get diarrhea. Then that is significant. That is significant.
Yes.
But here, 6 months diarrhea, is it of any consequence? It's of no consequence. Laxative abuse, if it's laxative abuse, then we should have had constipation. So this also will not come. Okay, now before you go to the next, any colonic pathology that can present with this intermittent diarrhea. Microscopic colitis. Microscopic colitis. They'll present as watery diarrhea. They behave, they have, and they behave, comes as an important DD for IBS in the younger age group. So microscopic colitis is one condition where you can have watery diarrhea, you can have large volume, and it will be painless. They'll present like this. But what will not happen there? They will not have any vitamin deficiency or micronutrient deficiency. Have you understood? Have you understood?
Yes,
large intestine pathology will not have nutritional deficiency.
Yes.
Okay.
Yes.
What is autonomic entropathy? That is one thing that you must keep. These are new terminologies. Autonomic entropathy. So they can have anti-glide, anti-enterocyte, anti-Robertson antibody. Yeah, so you can have all these which are now known, where you can have a combination of small intestine and large intestine. Large bowel.
Yes.
So you come right down in the list because it is again autonomic entropathy is again from the enterocyte. I was discussing about floridoria, Hartman's disease, floridoria, as well as cryptosporidiasis. Don't forget autonomic entropathy. What's it called? Microscope. Collagenous 2 or
lymphocytics.
Autoimmune entropathy. Autoimmune entropathy.
Yes.
So don't have so many no histories.
Okay.
You have to say during this entire period of illness, the patient has had overall a period of time, she's had loss of weight and loss of appetite. However, now just important things that we mentioned. There's been no history of any abdominal pain at any point of time, nor has there been any noticeable mass by the patient. That's how you build up. There's no history of any cough or fever. Patient is not a known diabetic, nor is she taking any treatment for hypothyroid state. There's no history of palpitation or heat intolerance. See, the way you just merge the history. Just merge the history. Okay, that's all that you have to say. Nothing else you have to say. There are no extraintestinal manifestations in the form of oral ulcers or skin changes or eye changes. Why did you ask for that? Certain conditions like Behçet's disease, all these conditions can have eye changes and they can also have diarrhea. The art of presentation is getting the history right and bringing the history towards, direct your history towards a diagnosis, because you examine the case. You've got the trump card with you to play that. You know what the probable diagnosis is. Because on examination, you have seen the patient. We do not know what it is. You understand?
Yes, ma'am.
So see that there are not too many no histories.
Yes, sir.
Okay, next move on. In the part for number of she admitted that this no cause. So don't say all this. She was evaluated and no cause was found. Don't mention all this.
Okay, ma'am.
So that's what I said. So for each of these episodes of diarrhea, she would often visit a family physician. She would receive supportive treatment, including IV fluids. Yes. She would get a temporary relief for 3 to 4 days, only for the symptoms to recur once again. She's had no major evaluation or investigation, and she is admitted to this hospital with the above complaints. That's it.
Okay.
Don't say no endoscopy for this person. Why do you want endoscopy for this patient? You understand?
Yes, ma'am.
And don't say no cause was found, as though you're going to find the cause. We're not demigods, no? Yes. When a good physician would have also picked up the cause diagnosis. So don't mention all this. No cause was found, and no endoscopic procedure was. To me, to be just this, Dr. Vaidhi asked, but I asked in the OP, did you have any endoscopic procedure? I would really not bother. If endoscopy was done, the doctor would have treated her, no?
Yes, sir.
Apparently, she's come.
Yes, sir.
Because the basic investigations have not picked up anything. So this ECOG performance scale will come as a global physical assessment scale with a performance scale of what it was right there.
Yes, sir.
So in your history, we use, what's the next one? Past. Next is what? Past history. So now just go back. So what I would say is this one. Up to here, what I want you to do is history. You divide it into 3 or 4 parts.
Yes.
First will be don't have too many chief complaints.
Yes, sir.
And then first and foremost, a mistake that you made was the relationship of the temporal relationship. And then bring in this particular history. So first will be expand on the diarrhea. We'll start with, which is pain. First will be the onset, sudden onset or whatever it is. And then see now the other thing is, now I saw the next slide of the drugs. So you have to mention here that patient is a known diabetic or hypertensive, because if something is there related to this particular thing, that has to come in here.
Okay.
You cannot bring it in the past. Okay. It's not a past history.
Yes.
If the patient is a known diabetic and a hypertensive, or she's a known case of tuberculosis or non-treatment, all that will come as a present history.
Present. Okay.
It is obviously not a past history.
Yes.
And whether she was on any medication, because you know that medications can cause diarrhea. You know, like metformin, no? You know, metformin causes, sartans are causing diarrhea nowadays, telmisartan, all the sartans are causing diarrhea. But they'll all be classically watery and to be real water-like, typical watery diarrhea. But they will have some exhaustion, but it's not really a secretory type of diarrhea.
Yes.
So all that will come here. It will not come as part of the past history. And she's been continuing on this medication. So that you can either bring in here, or you can say that she was diagnosed then, no problem. So divide your history into the chief complaint, expand on that, number 1. Okay. Once you finish that, bring in the consequences of that particular problem. After that, you bring in the effect of nutrition in every case. This particular disease, is it having any effect on the nutrition? From the nutrition, try to see, has she lost weight as like sarcopenia? Has she lost frailty, which will come as a performance scale that will be described as a global physical assessment scale and performance scale. Once you finish this, before you go to the investigations and management the patient had, just see, have I done a complete survey of all the systems of this patient? Now, from the CNS, this particular patient, you may have some gait disturbance. Okay, there's a B12 deficiency. So just see that you've mentioned, so you come as part of the nutrition. So I've asked so that you have tick mark that. For respiratory system, okay, I must ask for cough and fever because my DD is 1 tuberculosis. So have I checked? I've asked for that. Now she's got edema of the leg. So I've asked for breathlessness or autopnea. Okay, I'm okay. I've completed that. Then you come to the abdomen, most of the questions you've asked, but then you have the adrenal gland there. So whether any dyselectrolemia is there, that's the only question that you ask for the kidney. Urine output. Is a urine output good? That is very important. You have to mention about urine output in this patient. So much of diarrhea is a urine output normal. or she gets dehydrated and urine output is not there. That's the most important.
Yes, ma'am.
Understood? So you've done a couple. Then you come to the skin. Oh, have I asked for skin? Yes, I've asked. I've asked for oral ulcer. I've asked for skin ulcers. I've asked for changes. Joint, yes. So skin, joint, CVS, respiratory, cardiovascular, kidney, adrenal gland. These are only few things that we have. Then you have the skin, joint, as well as the, so that you've taken a history of everything or have not missed anything. Okay, and then say for this entire period of illness, patient was often getting hospitalized for IV fluids intermittently, and she would get temporary relief. She's not been investigated, and she's been referred to this hospital for further management. Finished. Don't say she should not undergo endoscopy, she should not undergo colonoscopy. What? And no diagnosis was made now. What are we going to do? We are also not going to do anything greater than what the physician has done there.
Yes, sir.
Have you understood? These are the parts of the present history. So first chief complaint history, then bring in the performance, global physical assessment scale, nutrition. Do not forget the nutrition. See that you've done a complete survey of all the systems. Don't keep on saying no history of headache and all that.
Yes.
This is for you. This is a checklist for you. This is a checklist have I taken so that you don't miss anything.
Yes, sir.
This is a checklist. And then investigation. The fifth portion is the investigation. And then you go to the past history. Okay?
Yeah.
Move on. Move on.
No, in the past history, she had a.
No, see, this is not past. Go back. Past. This is arthritis. So she's already a known case. No?
Yes, ma'am.
That's what I said.
Yes, ma'am.
So you'll have to say that the patient is a known case. She's been on treatment for arthritis or connective tissue disease or whatever you want to say for 10 to 12 years and has been taking treatment across the counter for this period of time and details of which are not known to her. But you have to mention it.
Yes.
Supposing she is on Brufen or Combiflam or one of these ibuprofen combinations, then she can be nephrogenic.
Yes, ma'am.
Or she can have NSA-related enteropathy. So all this will come in the present history because it's an ongoing disease.
Yes, ma'am.
So you cannot say she was normal until February.
Okay.
She's a 72-year-old. No, my patient is a 72-year-old lady who's been on long-term follow-up for joint ailment and has been taking intermittent treatment for arthritis or whatever it is, details, and it's a definite treatment. Across the county, she's been taking. With this particular background, she now came with a history of diarrhea. So that finishes that. So there can be a discussion on that particular aspect. Okay.
Ma'am, if we say patient is having 10 to 12 years of arthritis, so if we say chief complaint of diarrhea since 6 months, and if we start like this.
No, that's what I said. How did I put it across? She's not normal now.
Okay, ma'am.
So she's not a normal person until February, no?
Okay.
And when I say she's normal until February, means she's healthy, hale and hearty. There's no problem.
Okay, ma'am.
So you'll have to say patient was doing well until February. And then you can mention this. All this you can say. Before you go to all this is in a background of the patient being a known case of arthritic disorder, these details of which are known to her. And she's been taking medication off and on across the counter for this period of time. And don't go to the past. She's also known hypertensive and a diabetic. You can either say it as past, because it's not a past. Yes. Diabetes and hypertension is an ongoing problem.
Ongoing.
Okay. So she's on hypertension for 15 years and on, but she tells you the name of the drug.
Ma'am, patient's son.
So don't disclose it. That's what I said. So she's been taking treatment for hypertension for 15 years with no change in the medication. That is important.
Okay.
Most important is the change in medication. She's also a diabetic or non-diabetic.
Non-diabetic.
Not a diabetic. And a hypothyroid for 10 years and on medication.
Yes, sir.
And has been on regular follow-up. So don't bring in so much of disclosure that everything is there. So you can say, don't bring it as fast. As you merge the history. Once you finish all that, then you say, patient is a known hypertensive on long-term medication. And she takes 1 or 2 tablets in a day with a reasonably well controlled with no recent change in the medication. She's also a known case of joint problems such as arthritis, the details of which are not known to her, which has incapacitated her day-to-day performance and she's been on across the counter. Because if she's on methotrexate, or if she's on biologicals, or if she's on some treatment, that has to be brought out here. Because today, right and left, the rheumatologists are giving tofastinib, they're giving all types of medications. Biologicals is rampant in that group. And maybe she's on biologicals, she's immunosuppressed, therefore she's having diarrhea.
Yes.
You understand? But if it's just occasional, and as you see the patient, you find there's a lot of joint disorder, there's joint, deformity and all that. Then you can also say that she's a rheumatoid arthritis. You can bring out that information. Are you understanding?
Yes.
Don't keep the examiner guessing. She's also a known hyperthyroid on treatment. The last investigations for all this was, say, 5 years back and has not been on regular follow-up, something like that.
Okay.
Because we need to know that, because maybe it's hypothyroid that's not under control. She's not a known diabetic. There's no history of cardiovascular ailment, and there's no history of tuberculosis, and no history of abdominal surgery in the form of resections of the bowel or any GJ procedures. You can mention no history of abdominal surgery, but keep in your mind the surgeries that can cause diarrhea, which can be a GJ, it can be resections, or it can be a short bowel or a short bowel, due to ischemia, short bowel. All these will come, okay?
Yes.
Okay, in the family history. So don't bring on tell me sartan. If the patient says, in fact, I never ever talk to the relative. I have never spoken to the relative. I'll speak to the patient and then I'll tell you want to add something. That's it. Either you say details of drugs are known to her, drugs are okay. Then continue family history.
Sir, ma'am, there is no significant family history, no similar complaint in the family.
So what all will be important in family history in such a patient? Neuroendocrine tumors, no? Neuroendocrine. So in your patient, we did not discuss that. We mentioned about thyroid, not systemic disorders, all your NETs. Can it be carcinoid? So, I have to ask for flushing.
Flushing, yes.
Can it be Zollinger? We discussed. Can it be carcinoid? This is the other one. Can it be a lipoma? Can it be a glucogonoma? These are all the ones that present as diarrhea, which can run in the families. Yeah, and men 1, men 2, and all will be, they're all autosomal. Yeah, they're all autosomal recessive or dominant. No? So that history has to come up. And always, as a policy and principle, draw the family chart and just say all are well. So that even if just put it as a regular basis, so that if something they ask, have you drawn the family tree? Then you say, I've drawn it. It's there. Okay? No history of IBD, malignancy, and all. Now, what will you ask in this patient? You ask for IBD in the family, 72-year-old lady coming for the first time. What malignancy did you ask for? What malignancy will you ask for? HNPCC, hereditary non-polyposis, that again can be, no? But the age is little further down, 72 years.
NET is there.
Yeah. Polyposis, coli syndromes, so that maybe she is, but it's more like sporadic if at all it's malignancy.
Yes.
Okay.
Yes.
And other important thing in the history, you have to mention constipation. So you'll have to say during the normal period, when there was no diarrhea, she would pass once or twice a day with a Bristol score of 4 or 5. That you have to bring in. In your description of the loose stool, you have to bring in the Bristol score. Normal color, consistency is watery with a Bristol score of 5 or 6 or 6, whatever you want to say. Because if it is 6, it's watery.
Yes.
But if it is 4 and 5, it is semi-form.
No, semi-form.
That you have to bring. In between, whether it became 2 and 3 or 3 and 4. And during the diarrhea, it became 4 to 5, or was it 6 further down? The Bristol score has to come in.
Yes.
Okay, move on. Next.
Personal history, ma'am.
This is diet history. Diet is separate here. Personal history, okay. I keep telling the same thing. Diet history is separate. Diet is not personal history. Patient is a vegetarian. Her calorie, first is the requirement. Always say, she's 72-year-old. Her requirement is, say, 1,200 or 1,500 kilocalories. She's a housewife. There are some 72 years old who are active. So some of us are still active at a higher age. So the requirement of calorie, protein, and all is dependent on the activity of the individual. So you'll first say, as far as the diet history for past family, first will be family, then socioeconomic. Bring in the socioeconomic first, and then bring in the personal history, and then the diet.
Yes.
What is the socioeconomic?
She presents with lower middle class.
Kupusami, you say as per the Kupusami modified scoring, she's this. Then they'll ask you what all did you ask for. So
she's a housewife, but she's housewife. She studied up to the 4th standard, means not graduated, only middle school.
You calculate. You calculate and tell what it is. Yeah. So what I'm trying to tell you is you have to give the per capita income and say she belongs to this category, because only when you get the socioeconomic, then you get your diet history. In the diet history, say she's a sedentary worker, she's a housewife, able to attend to a day-to-day work. The requirement of calories is so much, protein requirement is so much, she's deficient in calories by so much, and she's deficient in protein by so much. And for that, say people from Maharashtra may go to another center in Maharashtra, maximum they'll come to Hyderabad this side. Occasionally, some of you go to Delhi. So see that you have a normal diet chart for some of the regions. So if you're coming down south, just get a typical South Indian diet, which is common to almost all the southern states. Yes. Then have a typical North Indian diet for all. So then, one chapati is how much calorie, one egg is how much, one cup of meat is how much, one cup of fish is how much. Get the calories calculated ahead of your exam. So it's easy. So it takes 2 rotis. 1 roti is so much calories, so much of protein. You can almost calculate and keep it ready for yourself as a ready reckoner. Very important. So up till Andhra, Telangana and all, it's all almost the same diet. There's nothing much. In North, it will be northern part of North Rajasthan and all are all similar diets. Except maybe from the eastern parts, you may have a little bit of fish and non-veg more on that side. That's all. So see that they will ask you, how did you calculate? How did you calculate? So you must have a ready chart. How much is 1 roti? How much is 1 idli? How much is 1 small dosa? How much is 1 cup of dal? How much is 1 cup of fish? That's a common diet, day-to-day practice. 1 cup of sambar will be how much? 1 cup of rasam will be 1 cup of poha will be how much? That way, just get the diet in so that you have a ready chart and quick calculation. That will be common for almost every patient. Once you've done, you're coming to say to Hyderabad or going to southern parts of the state, just have this common diet, see how you quickly calculate and keep it ready with you ahead of the exam. So if it is just 2 idlis, just reduce the calorie and protein. They'll ask you how you calculate it. Okay, so be careful about that. Okay, then and then after the diet history, of which is socioeconomic, now this bowel and bladder and sleep is all in the present history. It's got nothing to do with personal. Personal history is something very personal to the patient. Smoking, drinking, high-risk behavior. These are all something very personal. It is confidential. You cannot, it's non-disclosures. Whereas sleep, bowel, bladder, all you should have finished. You cannot, how can you finish everything and then come back and say bowel movements increase at day and night time? Look at that. Your history is over. Okay, what is no ill habits? What's that?
When patient is not taking alcohol, not smoker, not chewing any tobacco.
That's all that will not be relevant here. So just say she's a housewife and does not have any other or high risk behavior or any. That's all. Just finish off with that. That's all. Because 72-year-old can be like we had a 72-year-old who was drinking alcohol. That's important. Does not consume alcohol. In Andhra and all, they have the reverse smoking. So I do not know how many ladies smoke, but all this is known there in that particular belt. So therefore, please don't bring bowel and bladder. Okay. It's all there. Picturation. I told you, you're taking out the kidneys there, so the bladder, the urine output is fairly normal. That's all. That will come there, not here. Okay. Sleep and all, already you've said she's disturbed at night, so that also will not come in. Okay, now move on. Summarize. Summarize.
72-year-old female lady presented with
was doing well until February with comorbidity. First is the comorbidity because that is definite. Your comorbidity is definite. It's a definite thing that's happening in the patient with a comorbidity of hypertension, hypothyroid state, and NSAIDs for joint problem, whatever it is, arthritis. Arthritis has presented with recent change in the bowel pattern in the form of painless,
bowel type of diarrhea, with significant loss, weight loss, and malabsorption.
Malabsorption, there's nothing in the malabsorption. Don't bring in malabsorption with a painless, frequent, small bowel diarrhea, both disturbing both nocturnal, including a nocturnal disturbance, with a significant weight loss in absence of and with history of edema of the lower limbs and recent history of anorexia and weight loss in absence of macro and gross micronutrient deficiency, but however with a history of macronutrient deficiency in the form of edema of the lower limb. That's all. That's all that you have.
Okay.
Except for that, except for the hyperproteinemia, you cannot say anything else.
Okay.
Weight loss, what are the causes of weight loss? It can be steatoria. Steatoria is something which is not seen, but it may be that she's having the steatoria. Okay, with an ECOG performance scale of 2. Yeah, that's fine. So what's your syndromic diagnosis?
So my syndromic diagnosis is chronic small bowel type of diarrhea with
chronic small bowel diarrhea
with macronutrient deficiency.
No, chronic small bowel diarrhea. Just bring in osmotic or bring in that most commonly secretory diarrhea, whatever you want to convey. So secretory type of diarrhea, no? But maybe a mixed, because we say sometimes there is a combination of reduced acid when she's not eating. So with the chronic small bowel diarrhea, that is a broad classification, yes, with completed painless diarrhea. Painless. Chronic small bowel painless diarrhea, complicated by anorexia, significant weight loss, and edema and hyperproteinemia. With a comorbidity of diabetes and a hypertension, hypothyroid state,
and arthritis,
on long-standing NSAID. Long-standing NSAID with the ECOG performance scale of ECOG 2. Yes. Now bring in, is it just chronic diarrhea? Now, does she have malabsorption? Yes or no? That's the most important. First is with or without malabsorption. Does she have so that will come in your discussion, or it can bring in your syndromic diagnosis. Is now few things we need to know. Is it osmotic secretory? Which is whether it is fatty, watery, or it is inflammatory. So you already said it's watery. So you've drawn the classification of watery diarrhea.
Yes.
Next is it secretory or osmotic will be the next component, with or without malabsorption. Now just tell whether she has, then bring in the etiology.
Patient having chronic painless, watery, small bowel type of diarrhea, small bowel secretory type of diarrhea with significant weight loss, and hypoproteinemia with comorbidity of hypertension, hypothyroidism, and arthritis for which she's taking NSAIDs for long term with ECOG performance of 2.
Yeah. Now, does she have malabsorption or no malabsorption?
When patient having hypoproteinemia, this may be lead to decreased appetite or reduced.
No. How do you define malabsorption? When you say patient's got malabsorption, how many macro and how many micro? It will hold true for choppers or whatever it is.
At least 2 different nutrients should be deficit. Either it be macro or micro. So macro will be fat, carbohydrate, protein, and micro will be fat soluble and water soluble.
So there's some weight loss without. So you can say probable malabsorption to at least protein. You can at least say there could be a hypoproteinemia. With hypoproteinemia, probably there's a malabsorption to the protein. Okay. So what will be your differentials? Anyone else would like to? We'll just stop here before he goes for the etiology water. Others, any doubts you have about the presentation? But this is the approach, this is how you present. Anyone else? You can just be interactive. It's a small group. Dheeraj, Harish, I can only see their names. Asta, come on, you can just, yeah. Any lot of disturbance is there. Vivek?
Yes, ma'am.
Any doubts you have at this juncture?
Final syndromic diagnosis, ma'am. Is it okay if we say only small chronic small bowel diarrhea with malabsorption and weight loss, or whether it is mandatory to comment on whether it is secretory or osmotic, ma'am?
Then you can modify if it is totally secretory, it's easy to mention, no? But you can just say chronic small bowel watery diarrhea because you give the characteristic. Okay. Yeah. Because we know that is gross. Because we know it's watery, it can be fatty or it can be inflammatory. So broadly, why not inflammatory? It's painful, it's painless. There's no blood or mucus, there's no tenesmus, there's no urgency. So automatically that goes off. The inflammatory goes off. Can it be fatty diarrhea? Yes, weight loss is there, but it's not a bulky stool, it's a watery stool. Whether she's losing fat, we do not know. Okay, but the watery diarrhea, so you've already given that classification of a watery diarrhea. Then you can just say that I would like to discuss whether it is osmotic or is it secretory. And then say at times she would find. So don't bring in too much of that when she does not take foods, does not have diarrhea. It's only when, suppose she stops taking carbohydrates, she stops taking milk, then automatically she will not get diarrhea, no? Lactose intolerance. So that has to come out in your final diagnosis. So in its absence, you can just say it's watery small bowel diarrhea, probably secretory diarrhea, probably secretory. Don't bring in too much of osmotic. Yeah. Okay.
Okay.
And they just see that this particular thing. Each examiner has their own whims and fancies about this malabsorption bit. Candidates have failed. So see that you have a proper definition of what is malabsorption. When will you say in a given clinical situation that the patient has got malabsorption? So it can be one macro with two micro, two unrelated compounds that you mentioned. That is most important. That's most important. So if you have that combination of a hyperproteinemia with a weight loss, that itself tells you. But as of now, there's no micro. No? There doesn't seem to be any micronutrient deficiency as per the history. From the history. So if at all she may be having two macro. So it's more of a chronic diarrhea. I would still say there's not much of a malabsorption. There's nothing to suggest a malabsorption of any micronutrient. She's not received any transfusion, so your iron, calcium, all these things have not appeared. Okay?
Yes,
so you have to go along with the examiner. They will stop you here. They will keep on asking, is there malabsorption, yes or no? So have a little column and first get the definition right. If I have to say malabsorption, this should be my definition. If I have to say it's a secretory, this should be my definition. It's osmotic, this should be my definition. If it is fatty, get the definitions right as you're sitting outside. And then when they pounce on you, then you just say, based on this, I still feel that the patient has got chronic small bowel diarrhea. Probably it's a watery type of diarrhea with macronutrient deficiency of at least protein, because there's a visible hypoproteinemia by the edema of the leg. However, micronutrient deficiency is not overtly manifesting in this patient. Examination may find, but not on examination. Supposing on examination you find there's cheilitis, or actually if you see angular stomatitis, then you can bring in the micro. As you see the patient, if there's palmar pigmentation, if there's knuckle pigmentation, you can bring in the micro. Yeah, you don't have to wait for the history, because how many B12 deficiencies really manifest? None of them manifest. Only as you see, you find knuckles are all pigmented, palms are all pigmented. You can almost spot and say, oh, it's B12 deficiency. Then you can say, as I was talking to the patient, I found this. So I think the patient at least has one micronutrient deficiency, which is overtly present. There's no harm. Okay? So now, what are your differentials?
Ma'am, can I ask?
No, other important thing is, why have you not considered large bowel diarrhea? I was discussing that.
Ma'am, there is no rectal symptoms.
Just keep the colon complete. Now, when they say colonic, start with the right side of the colon. Start with ileal. Start from ileocecal. So one is just no abdominal pain to suggest an ileocecal pathology. However, microscopic colitis will come as an important DD. It will come as an important DD. This collagenous screw extends even into the small intestine. Collagenous screw, which involves the large intestine and colon. So you'll have to say my other differential for this patient is second differential. Whether it is a colonic type of diarrhea, in which my first differential would be a microscopic colitis. You have to bring in that. In that, you bring in collagenous or lymphocytic. Okay, very, very important. Or it may be a villous adenoma. Okay. Or a villous tumors, which are secretory tumors. It can be a carcinoid of the large intestine. It can be a lymphoma that can present secretory. All these now, can you just give a DD for we discussed small intestine. What are the DDs for the colon that can present as watery diarrhea? Now just think again. Lumen way, nothing much in the lumen, but everything is in the wall, mucosa. So we discussed collagenous screw. That is your microscopic and lymphocytic colitis. That's one. Number two, what are the other tuberculosis?
Tuberculosis.
Tuberculosis will come, lymphoma will come, carcinoids will come, as ileocecal present as watery diarrhea. So I've asked for flushing, palpitation, nothing is there, so unlikely or less likely. And then comes the tumors, infective, inflammatory. Can it be vasculitis? Yes. Vasculitis with small intestinal bacterial overgrowth in the small intestine, not in the large intestine. Rheumatoid arthritis there. NAC-related entropathy again is small intestine, not large intestine. So for me, for the colon, my DD would be, what are my DDs? I'll start from the ileocecal, carcinoids, lymphoma, tuberculosis, colonic tuberculosis, which is all very rare, but they can present. If the person is immunosuppressed, they can have watery diarrhea. And it can be involving the colon, we do not know. And don't forget inflammatory bowel disease presenting for the first time. We have seen patients presenting as ulcerative colitis, presenting only with watery diarrhea. And then we keep on investigating the upper end, and then lo and behold, when you do colonoscopy, it's actually a pancolitis, maybe NSA related or whatever it is in this patient. So your second differential will be, while you're considering small bowel diarrhea, the number 2 would be a colonic form of diarrhea. My differentials would be, only thing, what are the now have a column in your answer sheet. Colonic diarrhea will be small volume, often blood, if it's rectal. So it all depends on the site of involvement. So you'll say if it's colonic diarrhea, the symptoms will be based on the site of involvement.
Yes.
If the patient is an ileocecal pathology, which is obstructive, then the patient will have pain. Some partial small bowel obstruction, which is not there in this patient. That's how you speak. However, lesions such as carcinoid can present as watery diarrhea. Bisch's can present as watery diarrhea. Ascending colon pathologies such as microscopic colitis can present as watery diarrhea. Tuberculosis, infective conditions like intestinal tuberculosis, so have the percentage right. See which portion, moment you say tuberculosis, they will ask what are the sites, how often have you seen. So in the immunosuppressed stage, we have seen colonic tuberculosis. Ulcerative colitis presenting as the first time. Ischemic bowel, they'll have again pain. Patient is already hypertensive. Maybe the patient's got ischemic bowel. So just to see that you have an answer for each of these. And to me, the sudden weight loss of appetite, bilious adenoma will present as watery diarrhea. They'll have watery diarrhea, then they'll have mucus in the stool, blood may or may not be present, and it can be intermittent. Understand? So your second differential has to come up as a colonic, small bowel, colonic diarrhea. Okay, what are the causes now? What are the possible etiology you think in this patient?
Someone want to ask the question?
Yeah, you can ask.
Ma'am, myself Maitreya here. Ma'am, I just wanted to confirm that if we say patient is known case of diabetic hypertension or arthritis, and we can start like that, okay, ma'am, patient is known case of this and she was doing well with medication and now she presented with this.
Yeah, then you're trying to bring in that. No? So what I said was that you start with the history patient and you say this is in a background of.
Okay, ma'am.
All this is in a background. Then it's easy, no? Then you're safe.
Yes, ma'am.
Yeah,
yes,
then you're very safe. Yeah, you mentioned like he presented, bring in everything, and just say all this is in a background of several comorbidities that the patient has, because you want to link up the comorbidity with the disease, either comorbidity or drug induced, whatever it is.
Okay.
I would always say that all this is in a background of this particular history is in a background, so that examiner is not guessing not too long. Yeah.
Okay.
So what is the etiology in your patient, Doctor Ramesh?
Ma'am, as patient having a small bowel.
No more discussion. Just list out what are the differentials that you have.
Differential will be, ma'am, one is the drug-induced enteropathy like NSAIDs or patient taking ARBs for a long time. Then
first will be, what will be your first history? What will be your first differential? Just keep the numeral, no? One is small intestinal bacterial overgrowth. Just keep this in mind. SIBO will come as number 1, sudden onset of diarrhea. And the patient has got already rheumatoid arthritis or vasculitis. So it will come as SIBO as number 1. Related to the comorbid states, number 1 will be SIBO. Okay. Rheumatoid arthritis, you've already highlighted, number 1. Number 2 would be drug-induced. Okay. Drug-induced because patients are on treatment for hypertension. We don't have the details of the drugs. The patient is also hypothyroid. Again, SIBO comes as a DD. And patient is also having NSA. So read about NSA-related enteropathy, how often they have this type of a diarrhea. There's so many patients with NSAIDs, no, but they don't have this type of a diarrhea. NSAID does not cause. So then they'll ask, okay, what are the various pathological changes that occur in the small and large intestine as far as NSAID is concerned. So read the chapter on NSAID and the mechanism. What is the clinical presentation of NSAID-related enteropathy, and what are the various medications that can cause? What is the classical presentation? Then you will have your trump card with you that this is the possible reason. So that is number 2. Then number 3
would be ma'am.
Can be a new onset diabetes, no? Can be a new onset diabetes. Not checked. No. She's not a known diabetic, but first time you investigate, you find it's 11.2 HbA1c, and the whole thing she's been missed. So she already has 2 comorbidity. So again, bacterial overgrowth. Okay. Then
will be inflammatory bowel disease, Crohn's disease. But
Crohn's will not come as a DD because it is painful. Small intestine is all painful. Classical Crohn's list: abdominal pain, anemia, hyperproteinemia. Only 3 symptoms: abdominal pain, anemia, hyperproteinemia. Classical features of Crohn's. So without that is small intestine. So we will not consider that possibility. Then immune deficiency state. Immune deficiency state with parasitic infestation. Opportunistic infection like cryptosporidiasis, giardiasis, strongyloidiasis. All this will come in an immunosuppressed state. She's 72-year-old. Maybe she's immunosuppressed, and therefore she has all these manifestations of a parasitic related diarrhea. It is very common. So you have to know everything about strongyloidiasis. You must know how a giardiasis present. Generally doesn't present as watery diarrhea. It's more of a fatty diarrhea. Strongyloid can present as a fatty or a watery diarrhea. Hyperinfestation syndrome. Look at the questions will go like that.
Yes.
No? So hyperinfestation syndrome. Then of course cryptosporidiasis is classical watery diarrhea. Then have cholera-like diarrhea. So therefore, immune deficiency state. Patient has got immune deficiency state in the form of IgA deficiency, and then has superadded infection in the form of protozoal infection like cryptosporidiasis, parasitic infestation like strongyloidiasis or giardiasis. Amongst them, strongyloid I would consider rather than giardiasis. Then they'll ask you. So again, read about these. When they ask you, what I would suggest is just read only the symptoms and etiology, symptoms and management. Don't go to, no one asks about genetics, no one talks about molecular biology. It's all just this. For all these conditions that we're discussing, just go back and read. Just go back and read what's the clinical presentation of giardiasis, what's the clinical strongyloidiasis, madam is talking so much, what's the cryptosporidiasis, what will be the presentation, and how should you, what will be the classical clinical presentation, investigations and management. Just the 3 aspects of each of these disorders that we're discussing. Now, can it be pancreatic pathology?
There is no pain, ma'am. There is no.
So then you say, instead of saying no, only say pancreatic pathology often would present typical of watery diarrhea. It can be a part of Zollinger, it can be one of the NETs, yes. functional NETs, gastrinomas. So it cannot be excluded. So you have to say gastrinomas is one of the important differential diagnoses in your patient. Okay, so men 1, men 2, you have to keep those as number 2. So I would consider number 1 as small intestinal bacterial overgrowth, number 1. I will consider number 2 as drug-induced because you have so many drugs in this patient, you have hypertensive drugs, you have hyper. Number 3 will be small intestinal bacterial overgrowth as part of all that. Number 3 would be NET. You have to consider NET as an important DD. Zollinger, gastrinoma, vicoma, glucagonoma, all these, including Addison's, all this will come as an important DD, number 3. Okay? And all the rest will be unlikely or less likely. All the rest will be unlikely or less likely. Eosinophilic, yes, it can be eosinophilic. Again, they'll be painful. So Crohn's is out, your eosinophilic is out. Then your lymphoma, yes, will come as an important DD. Small intestinal lymphoma. Supposing it is celiac disease, not missed, and now it is a T-cell lymphoma, then it can present as watery diarrhea. You understand? So just keep tumors. So I would always classify infection, inflammation, vascular, tumors. Only 4. And miscellaneous. Miscellaneous will be your drugs and autoimmune enteropathy. So 4 will come as your important DD. So infection, yes, parasitic infection will come as important DD. Inflammation, eosinophilic enteropathy can come as important DD. Autoimmune enteropathy, we've also said is inflammation. Then vascular, unlikely, but vascular rheumatoid arthritis, vasculitis, see how you get it. That can present as SIBO, can present as diarrhea, diabetes, again, autonomic, neuropathy, and then maybe she's recently detected. Hypothyroid, uncontrolled, can present as SIBO, can present with diarrhea, and then neoplastic. In neoplastic, it can be a lymphoma. Adenocarcinoma is uncommon, but NETs can present as watery diarrhea. So you just see, you get your DDs there because your workup will come towards that direction. Okay. So the stoppage here, the summary will be very clear. What is malabsorption syndrome? Number one. Most important, what are the components and what is malabsorption? Number two, see that you're very clear about your nutrient deficiencies. Then the second differential will be colon. Doctor, why did you not consider colon at all in the patient? Very important. So first we'll read, is there chronic diarrhea with or without malabsorption? Number two, is there a DD for your chronic? How do you say, or is it a combination of both? These will be two places where they'll stop you. They'll not allow you to move forward until you're very clear about this. Okay? Okay, we can move on. Any questions up to here? Okay, move on.
Ma'am, I just kept a few of the differences as you told.
That's okay. A chronic painless small type diarrhea. Just be very careful. This with or without malabsorption. Be very, very clear about this. Now, in your patient, would you consider tropical screw or celiac disease? That will come. So once you have a chronic diarrhea, what they classify it as, they classify it in fact as celiac. They put it as celiac in North India, and they put it as non-celiac enteropathy. So in celiac is your celiac and tropical screw on the side. The non-celiac will be all your miscellaneous causes. All the miscellaneous causes. Crohn's will not come as an important DD in this case.
I will.
Yeah, see, you brought in everything good. So just move on. So Crohn's will not come in. Drug-induced enteropathy will come in. SIBO, SIBO is number one. SIBO is number one, including jejunal diverticulosis. You've been for a surprise. Jejunal diverticulosis, no? Multiple jejunal diverticulosis present, just a small bowel diarrhea.
Yes, ma'am.
Yeah. Okay, so we've already discussed what are the causes. So, but you have to be very cautious, and if you've not asked anything about meat-related intolerance, but you brought celiac disease here. That's why I said there. Yes. In that history, for every disease, have all the causes in your mind. For every disease, just write down today what are the important manifestations of each of these diseases. Yeah? Yes. And what priority would you give based on? And read Dr. B.S. Ramakrishna's paper on tropical diarrhea. So he has a nice classification how to classify the causes of chronic diarrhea in the country. You can just look up chronic diarrhea in India and your tropical infections. So then you'll get across both ways. So autonomic entropathy we discussed. Then small bowel malignancy. Don't make this small bowel malignancy.
Yes,
malignancy. Lymphoma.
Lymphoma and NET.
Lymphoma. Yeah, that's what. Celiac disease related T cell. Then lymphomas will come as an important DD. And number 3 would be your NETs. NETs, they're also tumors.
Yes, sir.
Intestinal tuberculosis presenting as chronic diarrhea is usually uncommon, but it can occur in immunosuppressed patients. Yeah. They'll have ulcerative type. It's an ulcerative type. The presence as watery diarrhea with features of malabsorption. So, on examination?
In general physical examination, sir, ma'am, positive things are presence of pallor, presence of pedal edema, and hallux valgus.
Now, don't bring in no icterus, clubbing, cyanosis, and pyelonicus. Okay, so just in your case sheet, just draw the figure, you just put a circle for the face, eyes, mouth, nose, then bring in one neck, just bring in the chest, 2 hands, and just keep on ticking. You don't have to write anything in the case sheet. Hair lusterless or flat sign is present, something like that. And then faces are normal, if it is normal, or if there is any pigmentation. Then eyes, you're looking for, what are the things you look for? Bitot spots. You're looking for flicton. These are the things that you look for in the eye. And then oral cavity, you look for cheilitis, glossitis, angiostomatitis, and oral thrush. So just draw the line on the face, that's all. Then you draw on the neck, I must say the lymph nodes. Just ensure that I'm not missed on the JVP. Maybe she's got anemia. And draw the arms. In the arms, you're looking only for pallor, significance of the pallor of the palmar creases. And then looking for hyperpigmentation of the palms, looking for knuckle pigmentation for B12 deficiency. And then you're looking for koilonychia. That's all in the arms. Then draw the chest, nothing much in the chest. Nothing much in the chest as far as the diarrhea is concerned. Lower in the sick, you look for edema, pitting edema.
Yes, sir.
That's also just describe just that.
Okay, yes, sir.
Just describe that the patient is middle-aged or an elderly lady, alert. That's how you start. Alert, conscious, with conversant, is conscious of it, because some of these B12 deficiencies can cause, some sort of a dementia-like changes. So just be careful about that. So patient was bringing all that. And then first is vitals. Vitals, vitals are normal. Pulse is so much. Blood pressure is so much. Respiratory rate is so much. SpO2 is so much. Bring in that first. First is vitals. Alert. Patient is alert, conscious, conversant, is able to communicate. And as I examined her, she had the vitals. First is the vitals.
Okay.
The pulse was, and always examine pulse on both sides. Suddenly you'll find there's an apla there. So just see that you don't miss. Always see. Don't mention anything that you have not examined.
Yes.
Never tell a lie. That is something examiners hate. Okay? So you just say what you have examined the pulse of the right upper limb. You mention pulse is this. Rate is so much. Blood pressure in the sitting posture, upright posture, very important in this patient because you do not know whether there is this. Respiratory rate is normal, 16 per minute. Count the respiratory rate. So pulse, blood pressure, respiratory rate are this. And then don't say head to toe examination. Then in your mind you say patient has got pallor, oral cavity is normal. There's no cheilitis, glossitis, oral thrush. There are no peripheral lymph nodes. There's the palms are normal. There's no koilonychia. There's no knuckle pigmentation or pigmentation of the arms. And she has got bilateral edema leg, which is extending almost to the knee. That's all that you can say. What is the next thing that we'll examine? Nutrition. That's all. After this, immediately, nutrition. Then you say that her nutritional assessment included frailty score and sarcopenia. The mid-arm circumference was so much, the tricep thickness was so much. You see that you know everything about it, and therefore the sarcopenia score is so much. As far as the frailty index goes, she was able to walk for the 6-meter walk test I did. She was able to get up from the chair without any difficulty. And she's able to perform her day-to-day activities. So the frailty score is this. So finish off the nutrition as an important component of this. They're not worried about cyanosis and clubbing. Okay. And then either ahead of this, you mentioned about the cheilitis, glossitis, all the nutritional changes, or you bring in the sarcopenia, frailty, and then finish off. We've already said cheilitis, glossitis, we finish. So that finishes off that. And then finish off the sarcopenia, frailty index. That is all that you need in a general physical examination of this patient. Yes. Understand? So, and then skin is normal, that you have to mention, and joints, if there's any deformity, mention the joints. That is just the completeness of the whole patient. Okay.
Yes.
So no petechiae, ecchymosis and all, maybe more of vitamin K, no? So that will not happen in this patient. Spine and back examination normal, that's important. JVP is normal. BMI you mentioned, mid-arm circumference you mentioned. And see, this is what I said, vitals will come first.
Yes, ma'am, that will come first.
Yeah, bring in the vitals. First finish the vitals.
Okay, ma'am.
Then start mentioning about the examination in your mind. Draw that figure, and you don't have to write. Don't write anything in the paper. Just draw that figure of a fellow, a cartoon, and just start describing that the eyes are normal. The patient has got no Bitot spot, no angiostomatitis, cheilitis, as I described. Just bring in that. Then once you finish this assessment, you go for your nutrition assessment. Sarcopenia, as far as the nutrition assessment is concerned, the sarcopenia scores were this, without circumference so much, thickness was so much, hand grip dynamometer, if it's available, get that done, and the hand grip is so much. Then you should know what's Indian data is already available, what is normal and what is in her. So it will tell you, because nutrition is important in her. Nutrition is an important component of management in this patient. She's lost weight.
Yes, sir.
Yeah, so that is important. So therefore, that is important to bring in the nutrition bit first. And then once you finish the nutrition, that's all that is there to be done as far as the general examination is concerned. So vitals first, then come the full examination, and then the nutrition assessment. And then, of course, the spine and skin. Yeah. And then
Also, ma'am, systemic exam for
The systemic examination always start. In your patient, what do you write? Don't you write CVS, respiration, abdomen, CNS?
Yes.
Skeleton. Follow the same order. In this particular, last time when I went in February to them, there was a dextrocardia and it was missed by the candidate. You think we should pass the candidate or fail the candidate? He's talking about the liver in the right side. The whole thing is missed. Dextrocardia was missed. Why are you concentrating on the abdomen in this patient? How do you do examination? First would be cardiovascular.
Okay.
Cardiovascular system, heart sounds normal, tachycardia is present, not present, not present. Respiratory system, very important. Tuberculosis was your DD. Red sounds heard on both sides, no adventitious sounds. Finished. Abdomen examination was non-contributory. There was it was scaphoid. The liver and spleen was not palpable. Bowel sounds were normal. That's all. They're not bothered about inspection, inflammation, inspection, palpation, percussion, auscultation. They're not bothered. Just as the examination of the abdomen, to scaphoid, don't mention about the veins and all. They're not interested. They're not interested at all. Maybe sinuses, yes. That's all. Inspection. On palpation, liver and spleen was not palpable. Liver span was normal, 12 centimeters. Top space was resonant. There was no free fluid in the abdomen and bowel sounds were normal. Finished. Rectal exam, perianal and rectal examination was normal and not contributory. You have to go in this particular patient. Okay?
Yes.
No more. Now, that's what. Don't waste time. See, in this particular case, you don't expect anything, no?
Yes, ma'am.
This particular case, it's only history. That's what I said. So what I would do, even in the exam, what you should do, one trick is that you talk to the patient, ask the name, don't take any clues from the registrars. You'll always get misguided. And then start examining the abdomen first. Suppose she says, I have difficulty in swallowing. And he said, okay, difficulty in swallowing, nothing much will be there, but I must look for secondaries in the liver. I must look at the stop space, there may be a funded growth. That's all. Quickly put your hand in the right and finish off a cursory examination, the first go, and then sit and start writing the case sheet. Don't waste time taking history all along and then you find something in the examination.
Okay.
If you find something on the examination, then that's your trump card. Just see as you take the history, then you can bring in the two together.
Yes, sir.
There's nothing, so everything is normal, expected. No? So just put rectal examination is normal.
Yes.
And in this examination, one thing that you can do, what we would do if I'm this thing, I will ask for a microscope and look for the finger stall waters to put it in a microscope for the anemic trophocyte. You understand? Because that's something in case you have to start the patient on steroid or something. So what would you do? They'll say, then you would say that if at least you can say while doing duties and all, I would definitely take a sample and just check under the microscope for any trophozoites of amoeba or giardia.
Yes.
Trophozoites of giardia or not strongy. Strongy is more of a duodenal. You will not get it in the stool.
Yes.
Next slide.
Respiratory examination, other system examinations are not contributory. Respiratory examination, no added sound, bilateral, normal vesicular, breath sounds.
So always start with serious respiration, abdomen, CNS.
Yes.
CNS, you already said alert, conscious and all. You just have to say the motor system, sensory system was normal, posterior column was normal, reflexes were normal, gait is normal, and that's all. Higher functions are normal. That's it. Essentially normal. See, what I said takes not even 5 seconds.
Yes, ma'am.
But you have to mention it. So after examination, the differentials remain the same?
Same, ma'am.
Differentials remain the same. That's what I said. So I should have hit on my diagnosis, 80% I should be right on my history taking. 10% has confirmed that I'm in the right direction. So it's not changed. So doctor, would you like to change your diagnosis? You would say, my diagnosis remains the same, that it is a small bowel diarrhea for evaluation, presenting with, now is there malabsorption? There's only with hyperproteinemia. So it doesn't seem to be a true malabsorption.
Yes. And presence of pallor, anemia is also.
Yeah, anemia is present. If it's significant, then yes. So you can just say that at least one micro and one macronutrient deficiency is obvious. But otherwise, there's nothing else to say she's got malabsorption. And rheumatoid arthritis, you didn't find any skeletal changes. So it is more of arthritis. Did she have changes?
She has a hallux valgus in the right foot. Otherwise, no other skeletal changes.
The hallux valgus, what does it indicate?
It's a suggestive deformity of the joint. It's commonly seen in rheumatoid arthritis, ma'am. So, but only
one joint. Only one joint. It's not a gouty. It's not gouty arthritis.
Not gouty.
Mm.
No.
That will come as a DD, no?
Yes, ma'am.
Okay. So now, any questions up to here? All cross-sectional ways of discussing. This is what I do in the outpatient. I talk to the patient, I ask what's the problem, then I start putting I say chronic diarrhea, nothing's going to be there in the abdomen. Then I just quickly examine, then I sit down and spend about 5 to 10 minutes taking the history, proper history. And always just bullet, Don't write in detail, just bullet. First will be painful, painless. Volume, yes, no. Then consistency, yes, no. Blood, yes, no. That's all. Just keep on writing that and speak out. Don't write. Don't take time writing the history. Don't waste time. You have to spend time trying to say what questions can be asked in my patient. And that's what you start writing in your case sheet. Am I dealing with small bowel? Is it colonic? Is it systemic? What will be the presentation? And have that. So when they speak, when they ask you the question, the answers are already with you. All right. Likewise, on examination, don't keep writing. Just draw a cartoon and just write down that. Okay. So how are you? Any questions from the others who are there? Any questions? Then move on. Okay. Move on. So the differentials remain the same. Now, do you want to change? Do you want to change the order? Yes, so what will be a number one? SIBO will be number one. Okay, number one. Number two would be
drug-induced
NSA. Yeah, NSA related, or you want to say diabetes with SIBO again, or it is drug-induced due to drugs in hypertension. We do not know the details, or a hypothyroid state. So SIBO will come as number one. Number two will be parasitic infestation, which could be more like a strongyloid, or because she's lost weight, or she's that. And then number three would be
NET.
NET, exactly. You have to consider carcinoids, you have to consider NETs, functional carcinoid. In that carcinoid, functional NETs, the carcinoid will come as number one. Neoplastic lesions cannot be missed. And then collagenous flu or collagenous colitis manifesting as a small bowel with a combination of a colonic diarrhea. So you cannot be wrong beyond this. What is out is inflammation. Unlikely.
Yes,
maybe it's an autonomic entropathy. There's an autoimmune entropathy. That's one. That's inflammation. But ischemic, unlikely, less likely, no pain. And neoplastic you have to consider lymphoma. You have to consider tuberculosis. This will all come a little higher because there's a weight loss. Lymphoma may also come up just below SIBO. After drug-induced, I would consider lymphoma. I will consider intestinal tuberculosis, largely small intestine.
Yes.
Large intestine, small intestine for 6-month history. However, then they'll ask you what percentage will have systemic symptoms, what proportion will have tuberculosis. So you should know all this, the link between systemic symptoms. Doctor, there's no fever, patient has got no cough. Still, you want to consider, to say ulcerative forms of tuberculosis can manifest occasionally in immunosuppressed patients. Occasional patient with HIV and all, we have seen patients presenting as watery diarrhea. That needs evaluation. That needs evaluation.
Yes.
So that will come if you're high on the list. Yeah. And then read about villus adenomas, presenting as watery diarrhea. Read about NETs, presenting as watery diarrhea.
Yes,
okay, so the order has to just get modified.
Yes, sir.
And inflammatory bowel disease, in that you may consider ulcerative colitis, not Crohn's colitis, not small intestinal Crohn's, skip it all.
Yes.
And then you can say, sir, I have seen one case during my 3 years course. Like I remember this one particular case, that's why I'm quoting ulcerative colitis, where we had in one of the gyms a case from CNC Vellore, which presented as watery diarrhea. They kept on evaluating for malabsorption, all the tests, everything. Lastly, they said, let's start the colonoscopy, and lo and behold, it was just ulcerative pancolitis. Ulcerative colitis, which was just ulcerated, presenting as watery diarrhea. With no tenuousness, nothing. So you can just say, I've seen only one case, so based on that, I'm telling that. Now, I have quoted, so you can use that as a quoting.
Yes, sir.
So IBD, ulcerative colitis, not as Crohn's. Any questions? Okay. Now, how will you proceed to investigate this patient?
Ma'am, first I would like to investigation.
That's what the other thing is. I would like to try to, and all that. Don't use all these words. My level of investigation. First is I need baseline. You need a baseline. You need a baseline assessment to know her diabetic state. You need to know thyroid state. You want to know all this. So, what are the level 1 investigation of this patient? You ask for a CBC, ESR, and a pelvic smear.
Yes, ma'am.
No, because you tell you iron deficiency anemia, they tell you it's macrocytic, there's folate deficiency. So based on that, the takeoff will be from there. So you need a good CBC, an ESR, and a peripheral smear. That will be the level 1 with all the indices. You need the NCV, NCH, NCHC, and all those indices.
Yes, ma'am.
Number 1. Number 2 will be, now follow this. What this one way I teach, just see all the departments that support the clinical medicine.
Okay.
So you start with clinical pathology, then you go to the biochemistry, then you go to the microbiology, then you go to the pathology. So have this list in your mind.
Yes, ma'am.
And then if they ask you the priority, you have the list when you're sitting outside. When they ask you the priority, then you move towards that. So now clinical pathology, you would send the samples for CBC, ESR and all. Now, what will be the other sample that you send to clinical pathology? Urine.
Urine.
Urine is important because you can pick up your diarrhea. Maybe she's got protein-losing state.
Yes.
Because she's got hypoproteinemia. Maybe there's 4+ proteinuria and some amyloidosis. The whole thing is just amyloidosis. There's a protein-losing state. So urine. Other sample that you send is a stool sample. So the stool, what are the things you look for in the stool? First is osmolality. Osmolality. Then you do a macroscopic. First will be macroscopic watery stool. Then you do a microscopic examination for all the parasites. Read about all the parasites. You'll also ask for a special AFP stain for the cryptosporidiosis and Plasmonella and all the other microsporidium. And the microsporidium. So these are the stool. And then you'll also see the stool for fat globules.
Yes.
Just in case you're missing. So stool is very important. So read about stool examination in detail. First is macroscopic, then microscopic, then special test for malabsorption, which will be your Sudan-3 staining or fat globule. You don't expect it, but definitely you do it. And a fresh sample for cryptosporidium for acid fast. So you just read about that acid fast stain. It is 30% hydrochloric acid, unlike the regular acid fast stain. So they will ask you the difference. What is the special AFB stain? That question comes up then. Okay. And then you mentioned that, and then so stool. So now you finish the department of clinical pathology. Now you come to the biochemistry. So in the biochemistry, what all will you ask for?
A renal function test, liver function test.
The first will be your blood sugar.
Blood sugars.
Fasting and this. That's the first. Then you'll ask for electrolytes. Stool will be osmolality. Okay, read the osmolality stool. Stool osmolality very important. So stool is a very important component. What happens is you people just jump all over and forget the stool examination. So you'll ask for you'll ask for sugar. You'll ask for creatinine because you may need a CT. So you want to ask for the creatinine, and you'll ask for the serum electrolytes, and you'll look at the liver function test to know liver biochemistry. That's what it's called now. Where they want to know whether both albumin and globulin are both low, suggesting a protein-losing state. Okay, so you look for the protein-losing state. And then what are the other tests? So basically, then you ask for serum calcium, B12, and folic acid. And special tests will be for thyroid. You ask for T3, T4, TSH. Read everything. What is T3? What is T4? What is TSH? Some fellow will ask some questions related to that. And then, so this will be as far as the basic. These are all the basic. And serum cortisol for your addisomia. And serum cortisol, because you're trying to get HO. You have your list, no? So in that list, you just see what all I start. Stool cal protecting there. Yeah. You have the list. And with the list, you'll ask for special investigations. So then for carcinoma, you can ask for urine. Now you're asking each one. You'll ask for serum IgG, IgA, and IgM because you got the immune deficiency state. You ask for immune deficiency state, and then you'll ask for a IgG, IgM, IgA, and then you'll ask for urine for urine HIA, hydroxyindolelastic acid, so that you don't miss a carcinoid. Simple test. Have you understood? So first will be clinical pathology, then you have gone to the biochemistry. Now then we are going for the special investigations in the blood test. And now you go to the microbiology. The microbiology, we've already sent the stool sample for whatever they wanted. And nothing much beyond that. Once you finish all these 4, now we are not talking HPV screening, HCV screening. That we will check. And if you still feel IgG, IgM and all come down or something, you may ask for a CD4 count. That is much later. Okay. And then once you finish this, then you go, now you come to the radiology department. Don't come to your department first, radiology department. Finish off the chest x-ray, have a good ultrasound done to say that everything is normal. Okay, now you finish the radiology, nothing much is there. These are all your allied specialties which get involved with your management. Pathology is left alone because now the pathology will come in once you start investigating from your endoscopic point of view. Now you bring the patient to the endoscopy room. So before endoscopy room, would you like to do tests of malabsorption? That is something because you have a doubt whether there's malabsorption. You've already done B12. So read about tests of malabsorption, which is basically xylose, B12, and fat. Read all the three tests. The three tests are routinely done, xylose, B12, and fat. Fat, you must know, you do the steatocrit test. Then you have the stool or the 24-hour. No one does that now. Microscopic examination is sufficient for the stool fat. Xylose is more a pentose sugar. This is by absorption is by facilitated diffusion. So xylose tells you about the carbohydrate absorption. And B12 is a very good test. It tells you whether there's an R factor deficiency, Schilling's test, or there's a deficiency of intrinsic factor with the R factor. And you know what is the site of absorption. So B12, xylose, fat are the tests of malabsorption. In that, the stool has already come. So stool is over. B12 has also come. So xylose, no one really does. But you must know, earlier we used to give 25 grams. Now we give only 5 grams. And PSG and all, they have the facility to do the xylose tests, I think in CMC. And then for bacterial overgrowth, you can even go for special investigation as hydrogen breath test. Breath test. So SIBO was, so then you will say, based on the etiology, my workup would include, they're all special tests. For SIBO, what all will you do? You can do the bacterial overgrowth, you can do a journal aspiration, do the bacterial overgrowth study, you can do a breath test, you can do lactulose hydrogen breath test, you can do all the tests of malabsorption for the SIBO. So SIBO tests, parasites we've already said. Now just look at the way it's approaching, no? But then everything should be ready with you. So what the examiner may say, some fellow will be interested in something, he may just direct you towards that. Then you come to this. So before you go to the endoscopy, normally you see CMC, whether or not, this is what we will do. We will do all these tests and say whether the patient has got malabsorption, yes or no. And then comes the procedures we used to do. Those days the concept was more of a crossbreed biopsy, capsule jejunal biopsies we used to do. But over a period of time, we had the endoscopy coming up. Now, what is the role of endoscopy in this particular patient?
Ma'am, endoscopy, as I'm suspecting small bowel pathology.
No. So endoscopy means what? As you do the procedure, you look for thrush. You may just find there's thrush, no? And there's oral thrush, and the patient's got esophageal candidiasis. Then you say, okay, this is immunosuppressed state, or the patient's diabetic. No? So you get that information. Then you're entering into the stomach. Suddenly you find the folds are all huge. And you find it's more than 5 millimeters. Is it a this is metrias? Is it a lymphoma? Or is it Zollinger? So these are the things that would cross your mind as you enter the stomach. So always when you're doing a procedure, you always think what was there in the differential, which we said right at the beginning, can still be something in the stomach. And then you see the duodenum, first part, second part. And then you start looking for your features of celiac disease. Look for lymphangiectasia, the ice flake appearance, or you look for your scalloping, which is not very specific. And then what you do is you pass the jejunal tube or a tube and aspirate the lumen from the lumen for a culture and a culture for the bacterial overgrowth. The moment you say this, they'll say, what's the normal count? So normal count is only 10 to the power of 2 to 10 to the power of 3 in the jejunum. So it is but in India, the studies from Vellore have shown it's actually 10 to the power of 5 to 7. So it's not similar to what's reported in literature. Once you've done that, you will proceed and you will go as deep as you can into the third and fourth part and take a D2 biopsy or a D3 biopsy. And you will say, I take the biopsy, I'll put it on a filter paper, I will align it. We normally use a magnifying glass so that the mucosa is in the upper portion and the red dot, that is the biopsy portion from where it is taken, is in the lower portion. I would put this because ultimately what I'm looking for is a Crypt-Willis ratio. So you must mention this. We've been discussing this all along, even in ISG, some of the classes that we had, alignment of the tissue. We'll put each of them in a filter paper and drop it into the bottle. So that, what are you looking for? Basically, looking for the villus ratio, and you want to study the lamina propria.
Okay.
So this is the ideal test for 10. It will give you all that we said. You'll get the brush border, you'll get the villus ratio, you'll see there's strongyloid, there's a giardia, you'll see the lamina propria, what is a lymphoplasmacytic infiltration, is it IPSID, is it behaving like a lymphoma, or is it behaving like complete deficiency of IgA cells, plasma cells are deficient, so is it IgA deficiency that this patient has? Lot of information you'll get from the D2 biopsy.
Yes.
Up to here, you should, only when you finish this, then you go for your imaging studies.
Yes.
Nothing up till now. Up till now, you should be able to tell what is the diagnosis, what is the role of radiology, say CT scan and all. It's only for structure. It will not give you any information on the cause for the diarrhea. It will give you structural changes like strictures. It may show mesenteric fat. It may show vasa recti being prominent. It will show vaginal diverticulosis. So when all these tests are negative, then you proceed for high-end imaging, which will be a CECT with an enteroclysis or an enterography or an MRI enterography. Depending on this, you'll get your CRP, you'll get your ESR, you'll know it's inflammatory, non-inflammatory, and then the takeoff will be from there.
Yes, ma'am.
Have you understood?
Yes, ma'am.
So in your mind, just have this checklist, go through all the departments. I find this very useful. Have I missed any department which is supporting me? Then you will not miss any of the investigations. So can we have the reports, results?
Oh, yes, ma'am. These were the initial reports, ma'am. When he was admitted, her HP was 10, MC was normal.
So creatinine is slightly high, LFT is normal.
Rating, sodium
Albumin is
potassium
low.
albumin globulin was
CRP is high.
TSH HbA1c was normal.
No diabetes. So level 1, I'll not ask for TTG, IgM. We will get that much later. Yeah, I will ask, in fact, for IgG, IgM, and IgA.
Okay.
Opportunistic infections will all be special stain.
Yes.
Okay?
Yes.
And calcium, magnesium, everything is normal. Vitamin D3 is low. Yeah.
Yes, ma'am.
Chest X-ray, ultrasound, minimal bilateral. So that is hyperproteinemia.
Yes, ma'am.
Then nothing much. Okay, so this is all normal. But what we need is the test of malabsorption.
Yes, ma'am.
Xylose, B12 and fat. B12 is here. Stool fat. See, the stool examination, it's not routine. What you have to mention is the occult blood written as positive. Is it important here?
Occult blood is important, ma'am. Means if he sees losing.
So what precautions will you take to take stool for occult blood? Patient should be off iron, off vitamin C, off meat.
Okay.
Yeah, all that. Vitamin C. See that all these are not there for at least 4 to 5 days and then do the stool examination. Otherwise, you get a false positive.
Yes,
Next step. Calprotectin.
Calprotectin was 176. It was not that much high.
Yeah, CRP is high.
CRP is high. Terminal ileal thickening was there, and as radiology.
Nothing much. I would not really attach important. So what will be the next level? Next will be upper GI endoscopy.
Yes, ma'am. Upper GI endoscopy was normal. D2 biopsy was normal. And we could not do contrast enhanced CT as was create was high. There was
do we have endoscopic report?
Ma'am, actually endoscopy was normal. I haven't got
biopsy.
Biopsy was normal upper GI, ma'am.
Biopsy was not okay.
Then ma'am, radiologists were quite confident that
no, that's okay. So once you do an endoscopy and not God, you have to study the small intestine and the colon.
Yes, ma'am.
Yeah. Then, so then colonoscopy. Yeah.
Then we did colonoscopy, ma'am. There was presence of around 10 centimeter of terminal ileum was seen, and there was presence of few multiple large discrete ulcer with necrotic phase. Biopsy was taken. We could not go further as there was very colon mucosa was very thinned out.
So it's more like this is preserved. So there's no superficial ulceration. Ulcers are seen, but the this architecture is maintained. No?
Yes, ma'am. Biopsy report found to be likely suggestive infective.
But it looks more like an NSA related.
NSAIDs related. We have planned to do evaluation of small bowel further. We have asked the patient to stop the NSAIDs and come further, and we'll see again.
And so what we need is beyond this, you cannot just stop because of watery diarrhea is not explained with this.
Yes,
but you have to consider that possibility. If that is negative,
yes, ma'am.
And more important here, you take ascending colon biopsies for your ascending colon biopsy for your microscopic colitis and collagenous fluid. Yeah.
Yes, that was taken, ma'am. A multiple biopsy was taken, including ileum. The ileum reveal ulcers. Ileum reveal mixed inflammatory exudate, and there was preserve of ileum detected.
Yeah, but you have to rule out, as I said, no carcinoids, NETs. Do not forget serum gastrin. I say urine 5-HIA. You cannot miss on that because there is history of loss of weight, and you will ask for a good CT. If not CT, a good MRI non-contrast.
Yes.
What I find nowadays is MRI non-contrast gives you all the information that you need. T1 and T2 weighted gives you all the information without contrast. Contrast is more for SOLs.
Yes.
So in the presence of raised creatinine, so wasting time, you can just get some information on it. Like you can give oral contrast, no? You can give water. Yes. You can give water so that you can pick up the small intestine. That's all that you need.
Okay.
Yeah. If you do an MRI infography is all that you need. It will give you the structural changes in the small intestine. Understood? So that's the way you move forward. And once everything is ruled out, nothing is there, then you stop. First would be stopping NSAIDs, but you have to rule out carcinoid, you have to rule out gastrinoma, all these other pathological changes which requires special investigation.
Yes.
Okay, so I think basically you have to improve your presentation and be bold. Don't show that you're more knowledgeable. That's something. But at the same time, what I find students who really done well is you come like not like a consultant, but as a person who knows the subject well, and then say this is my first case, long case, and then you start your presentation. You don't have to be diffident. You don't have to be apologetic. You don't have to keep on saying sorry, yes, sir, madam, sir. Nothing required. And just present boldly. The chief complaints is this, and then start off with a bang. And don't waste time writing details in this thing. Next time when you're presenting, just write down by hand and project it as a PPT. Don't waste time preparing PPT. It's a waste.
Yes, sir.
And then you know exactly how it should be written. And then, as I said, don't like pedal edema. It's just a waste of.
Yes, sir.
Yeah. So anorexia, weight loss is there, but anorexia would occur over a period of time. Weight loss, maybe that she's got scared that she has this increased gastrocolic. Yeah. So read gastrocolic reflex. Okay. Yes, so in one of the DM exams, Delhi, we had 10 years history of watery diarrhea. And candidate did not speak at all about IBS, okay, and did not speak at all about collagenous fluid, lymphocytic, microscopic colitis. So, like the common things are common. So I remember that as I was discussing, I remembered that particular case. That's why I said colonic pathology cannot be ruled out in the presence of a small bowel diarrhea. In that, differentials are very few. Ulcerated lesions, the colon presenting for the first time is IBD. Number 2 will be lymphomas. And third will be intestinal tuberculosis. And not to forget microscopic colitis.
Yes.
So we are pretty confident and don't haphazardly bring in the investigations. So when you're sitting outside, you write baseline evaluation for management. Next will be specific investigations, diagnostic tests. So they say, doctor, what diagnostic test will you do? Then you should go straight to your second table. Yeah. And the third column will be tests which you need for follow-up. For example, for this patient, I need CRP for follow-up. I need an ESR for follow-up. I may need a thyroid function test for follow-up. These are all tests for follow-up.
Yes.
Okay. And don't forget this autonomic, autoimmune enteropathy. That is something that's looking at. Okay, any questions from anyone else?
Postgraduate students, do you have any questions? Because this is a golden chance that Madam is sparing so much time for you on Sunday. So, if any questions, Madam,
you can stop sharing the slides and then you can just ask anyone. If you have any, it can be frank, it can be, what I want you all to know is just the presentation should be good. So switch off the sharing and anyone just come up. Don't be hesitant.
Bhavin, Dheeraj, Harish, Vivek, Maitri, Astha.
Just if you're comfortable, no problem. But if you have any doubt, it can be this is the time you can discuss. Bhavin, anything?
No, ma'am, no problem.
Yeah, but just the time when the candidates fail is when they have this malabsorption versus small bowel versus colonic diarrhea. Number 2 is this malabsorption versus no malabsorption. You have a very clear concept of that. Most of the seniors who are sitting above the age of say 55 onwards would follow this. But the youngsters, who like you people and all, would go straight from CT and endoscopy, but that's not the approach. So invariably, you'll have a combination of a senior person along with the juniors. That's how it's happening now.
True, madam.
Yeah, it's a combination of, they have at least 2 seniors and two juniors so that they get a hang of how to conduct the exam.
Right.
Okay.
Kamlesh, anything?
I think they're comfortable.
Yes.
Yeah.
There was one question. A patient having no dyspnea, means there is no history suggest of any specific disease. Still,
which one? No history of
any specific. Just like in this patient has no dyspnea, no flushing, no urticaria like symptom. Still, we keep NET. So ma'am, any examiners gets annoyed or anything like, or can we defend like this patient is painless diarrhea? I would like to keep in this even.
NETs will come. So today you go back, just read the classification of NET and see what's the presentation and make a list.
Okay.
Just make a list. What will be the presentation of a pancreatic NET, functional versus non-functional, and then so you have that, and it's mentioned then specific that this what is the presentation.
Yes.
So carcinoid, can present watery diarrhea, and maybe that ultrasound picks up the SOLs. Until then, you do not know, it's functioning or non-functioning. So therefore, a cardiovascular system examination becomes important because you have pulmonary hypertension carcinoids. Yes. So whatever I've said today, follow the same pattern: cardiovascular, respiratory, abdomen, CNS, skeletal, skin. You will not miss anything. If you start with the abdomen, you will miss the rest because you don't focus. What was there in this abdomen? Nothing. On the other hand, suppose he had pulmonary artery hypertension and P2 was elevated, then at least you know something is there. Yes. And he's got an MR or a TR or something there. Then you can say that it's helping me with the diagnosis. Yes. So the patient has asthma-like symptoms and again becomes a carcinoid. Yes. So always, if you follow a natural, normal pathway, see, we as gastroenterologists are also physicians. Yes. So you have to remember that. So suppose this patient has got cardiac manifestations all over. So recently we had a patient who had raised AST-LT, but he had a transposition of the truncus arteriosus operated, and there's a murmur heard all over the chest. Now you cannot ignore it. Yes, ma'am. You cannot ignore such findings. And imagine a DM, so a DM candidate is appearing for a DNB exam with the dextrocardia being missed. What should we do with a candidate? Then you blame the examiners. No, but look at that. It's such a gross mistake, huge mistake, and describing liver is palpable 5 centimeters. Everything it goes on. He needs a 0. It's a 0, no? Because you've not picked up a dextrocardia. And always, you don't have to do an ophthalmic examination. There are some conditions where you need a fundus examination. So always carrying an ophthalmoscope, CNS, do a quick see. Try to pick up CNS findings in 3 minutes or 2 minutes. Okay? Yes. We've got two systems working.
Ma'am, in such patient, we have to do proctoscopy or
No proctoscopy, rectal examination sufficient. Proctoscopy don't do the patient. And conditions where it is not relevant, you need not do it. But please ask don't tell a lie again. Patient, you have to say, I ask the patient if I could do a rectal examination. Nowadays, examiners are very clear when it's not, say, dysphagia case is not required. They're very clear, they don't want you to trouble the patient also, but just ask the patient, can I do a rectal examination? They say, no, I don't want it. Then you say, ask for it, and patient refuse for the procedure.
Okay.
But no need for a proctoscopy. No. Okay, close down. Thank you, Dr. Rajiv.
Thank you, madam. Thank you very much for sparing this time.
No problem.
Thank you. Students will definitely be helpful. Thank you so much, ma'am.
Thank you.
Thank you, ma'am.
Plan
Thank you
for
very
one more
much.
day sometime in between. Yeah, thank you.
Thank you.
Thank
Sir.
you,
Thank you.
Thank you very much.
Thank you, ma'am. Thank you, sir.
Thank you.